Good morning. Thanks for your time this, I guess, afternoon now. Let me start off with just some basic statistics. Today, across CHI Health, we have 208 hospitalized COVID-19 patients. If you look back at last Tuesday, so exactly a week ago, that number was 174. What's interesting is that the number of patients in the ICU is 51 today. A week ago, it was 51. So that number has been relatively stable. But we do have about 20 patients this morning requiring ventilators. That's up 6 from a week ago. A week ago, that number was 14. So as you all have seen in the media and actually have been reporting, we are seeing an increased demand for hospitalization or for hospital beds, really driven by the increasing rate of infections that are occurring in our region, Southwest Iowa and across the state of Nebraska. So given that this trend continues upward, and I think as I reported last week, a few weeks ago, we were down half of what we have currently in terms of the number of patients admitted to our hospitals. And if you look back at our peak, our prior peak, which was at the end of April, at that point, we were up to 107 hospitalized COVID-19 patients. So we're seeing, a substantial increase in the number of not only infections in the community, but then the resulting hospitalizations. So I'll stop there, and Anissa, if you want to start reading off the questions, I'll try to respond to as many of them as I can.
Yes. The first question is regarding elective surgeries. What kind of elective surgeries are you stopping, and can you share an example, please?
So the way we're approaching elective surgeries this go around then that is different than in March and April is, first of all, we have a lot more information about the virus. We understand better how to treat patients that are infected with this novel coronavirus. And so we feel much more comfortable that we can manage both our capacity as well as continue to provide necessary health care at the same time, do both of those things in parallel. We are, though, beginning to evaluate based on just the increasing trend of admitted patients to the hospital. We are now implementing a process where we're evaluating our procedures, and procedures that meet a handful of criteria. We are under the advisement, and in partnership with the surgeon or the specialist, we are beginning to start to postpone certain types of cases. So let me give an example. What we're really looking at is the cases or the individual patients that might require an extended hospital stay after their procedure, that might require ICU level care after their procedure. And given those variables or those potentials, we then are evaluating the actual clinical reasons for the surgery or procedure. So an example of something that we would likely postpone would be maybe somebody that is been, has arthritis of the knee, that has been on the list to get a surgical replacement of that knee. They've been, they're not taking a lot of pain medicines. They're not in excruciating pain. This has been something that they've been, their surgeon has been following for, months, or in some cases even, more than a year. That might be the perfect kind of case, particularly if that person had other medical problems and might need a longer hospital stay, or might even need an ICU. That would be the perfect type of case that we would work with the surgeons and talk about postponing. People that need heart surgery or cancer surgery or other things that are more significant or critical, those we can't delay and postpone. And we went through that the first go around in this country where we stopped all healthcare. We still believe that had very significant ramifications to those patients that needed those necessary services. And so we're not going to do that this time, unless we just absolutely get forced because of overwhelming numbers of COVID patients that are being admitted to the hospital. But we're nowhere near that as of now, and and don't actually even think that that's a likely event. So hopefully that helps you all understand that we're going to continue to take care of folks, particularly folks that are the ones that are truly in need and have issues that need to be addressed sooner rather than later. But we also are going to try to maintain capacity in our facilities by postponing things that we can safely postpone that won't have a negative outcome for that individual patient.
What do people do if they have a surgery scheduled? Do they need to call? Will they be notified if there's a postponement?
So yeah, let me be clear. We're not asking folks to unilaterally make decisions about their own case. If we believe their procedure or surgery is one that can be and should be postponed, we will reach out to the individual patients. So the way I would reframe that is, if you've got a surgery scheduled for later this week or next week, unless you hear from us, you are moving forward with your procedure as scheduled. We recognize the impact on patients and their families who, have, go through quite a bit to get a procedure scheduled, to have people's time off arranged, you name it, and then to just have those postponed. We know that's not simple to do, and it's a big deal. And so we're being very careful, very thoughtful, but we would also suggest to patients, don't you then, make a decision unilaterally. Wait to hear from us. We will reach out to you if we think their procedure needs to be postponed, and we'll work with that patient individually to get that rescheduled.
What do the numbers need to be to resume normal operations?
Well, as I've said in the last couple of weeks, we're used to managing our hospitals, any given day, starting off the day at 85 to 90% of capacity. That is just normal day-to-day operations for hospitals and for healthcare systems. What's different about where we find ourselves now is this increasing demand for hospital beds because of the COVID infection that continues to increase and is above what would be our normal kind of activity level in terms of patients in the community that require hospitalization. So what we've committed to the governor to do, as of all the health systems, is to maintain capacity so that if there continues to be an increase in demand because of COVID infections, that we can meet that demand with our facilities without just unilaterally shutting down all procedures and stopping all other healthcare. So what we're really watching is what the trend is in terms of the number of new infections and therefore the number of likely hospitalizations that would recur as a result of these new infections. And so it is our objective is to make sure that we maintain capacity to be compliant with what our agreement with the governor is, and do that by managing our utilization of services based on the demands that we see day in and day out. So that's why, for instance, I started off by pointing out that a week ago we had 174 COVID patients. Today we have 208. If next week we have 248, then we will continue to be ratcheting back the other things that we're doing to make sure that we've got adequate, supply of beds and staff to be able to care for those COVID patients.
When did CHI Health begin limiting surgeries, and for how long will this last? And is it at all your facilities?
So it's a case-by-case basis. As I said, we've begun notifying some patients that had procedures later this week that we think would be best served to postpone. So that is happening, sort of as we speak. We again are working with the patient's physicians, because ultimately it is the clinician's call as to whether or not a patient a patient's procedure can be safely postponed. And so, it's not something that we're just doing, broadly. It is a case by case, physician by physician decision. And again, it's really driven by the things we think can safely wait a month or a couple of weeks up to a month or so to be rescheduled. The primary reason, again, is to just make sure that we maintain some hospital bed capacity for what looks like maybe an increased number of patients requiring hospitalization due to the COVID infection.
And that was the last question about elective surgeries, was the reasoning behind, and I think you answered that. Can you tell us a little bit, you mentioned visitation policies possibly changing. Can you talk a little bit about that?
Well, so a couple of things. So we are evaluating the visitor policy and have made the decision that we will begin to modify our visitors policy so that we are again are limiting the risk of exposure to both staff and, quite frankly, to patients, given the high preponderance of cases in the community. So I think, initially you can provide them the written information after the call, but we will be scaling back. We'll be asking patients to have just one visitor. We are going to ask that we scale back our visitor hours so that those will, I think, run from 7:30 to 9:30. And we are expecting visitors to wear a mask the entire time that they're in the facility, and particularly, that is to protect the patients who are the most vulnerable in our hospitals from spread that could be brought in via visitor. We're not suggesting, or I'm not suggesting, that folks aren't taking this seriously. I know they are. We just know that with this virus, one of the biggest challenges is that so many people can carry this virus, can potentially be contagious, and yet not have any ill symptoms at all. And so, given that fact, with this infection, we have to be particularly careful, particularly when we're seeing test positivity rates in our communities above 20%, which is within our own labs data this morning, the results. So these were tests that were run yesterday in our labs across CHI Health. We were approaching 30% of the tests were positive. And again, very few of those patients that were tested were actually in our emergency departments or in our hospitals. Those are tests coming from our clinics and other outpatient testing sites that just shows you that the virus is widespread in the community. And so, given that fact, we've made the decision to scale back on some of our visitors policies.
Yes, and I'll be sending out that press release later today to the media. We're going to move on to a different topic. How are hospitals handling non-COVID emergencies?
So we're encouraging those of you in the media to help deliver this message as well to the general public. But we cannot allow the public health impact of not providing care, and for folks that need care not seeking that care because of the virus. So we are absolutely still handling every trauma case that comes in through our emergency rooms, all of the strokes and heart attacks. Our hospitals are not full of COVID patients. So in spite of the message sometimes we seem to deliver, we absolutely are taking care of everything, and we want people in the community to know that if they need medical care, they shouldn't avoid coming, seeing their physician, coming into one of our hospitals, because the negative impact of that is delayed care usually ends up not being something that is good for the patient. It tends to allow conditions to worsen, to become more severe. And so we're encouraging people that need healthcare, that have reasons to utilize healthcare resources, their physicians, their hospitals, to please continue to do so. Again, as I said, we had 208 COVID patients today. That's out of about 1,100 hospitalized, or the capacity of 1,100 just in our system alone, without doing any, additional kind of surge planning. So there's, the hospitals aren't full of COVID patients. There are more than we've seen over the last 6 months, but there's still plenty of capacity to care for all the other things that need to be cared for on a timely basis. So I would just encourage folks to just keep that in perspective and not delay necessary care because that isn't good for the individual patient.
How do you decide which patients are sent to other hospitals if they are transferred?
So the CHI Health has set up its own transfer center that we've had in place for years that just facilitates the movement of patients that might be in a hospital in a community but need a level of service or a type of service that hospital couldn't provide. So we've built this infrastructure. We've had the capability to move patients from outlying communities into Lincoln or into Kearney or Grand Island or Omaha as needed. And it's that infrastructure that we're now using on behalf of the state to help facilitate COVID patients that need to be transferred, either because there may not be a bed in their local community hospital, or they may need a level of care that the local community hospital isn't able to provide or is out of capacity. So the transfer center, and we're averaging, I think, anywhere from 8 to 10 calls a day to place COVID patients. And what they're trying to do is find the hospital that has the capability that is closest to that patient's home and make the transfer, from maybe the local community to the next closest community where that patient can be appropriately cared for. It's really driven by the level of care that's needed by that individual patient, and then therefore the capabilities of the healthcare system in that local community or in the surrounding communities. So hospitals, and this goes bi-directional, right? So our hospitals, like in Kearney Good Samaritan or St. Francis and Grand Island, we can move patients out of those hospitals that are recovering, that are improving, that need a lower level of care, meaning they're not in the ICU. We may actually move those patients or transfer them to one of the surrounding community hospitals that can provide great care for them, but and doing so allows us to free up capacity for the sicker, more urgent or acutely ill patients. Again, not something unique to COVID. We do this normally. This is what happens in healthcare, but now we're doing it, more purposefully and more frequently to make sure that we maintain capacity. The way that would work, just quickly to give you an example, is we may have a patient in our ICU at St. Francis. They may no longer need ICU level care and can be stepped down either to a PCU or even to a med-surg bed. But if all of our med-surg beds are full, then we can't move that patient out of the ICU to free up an ICU room. So what might happen is then we might have a patient that lives in a surrounding community that we could transfer from St. Francis back to their local hospital and do so safely. That would free up a bed to allow us to move that patient out of the ICU, freeing up an ICU bed for a more severely or acutely ill patient. So we have a team of nurses that work in our transfer center. We've got nurse leaders in all of our facilities. This is what they do day in and day out, is understanding how to manage the needs and the demands that are driven by the patients with what resources are available. And sometimes that means we're moving patients from one hospital to another for a higher level of care. Other times it might mean moving a patient from a hospital to another hospital for a lower level of care, to be able to create capacity for more severely ill patients. So it was a long answer. Hopefully you can get a gist of it. We're constantly flexing and moving to make sure that we've got capacity for that next sick patient that might show up at our emergency room.
Yeah, and that takes care of the second question in this series. Part of that question, though, did ask if we work with other non-CHI Health hospitals when we're transferring.
Yeah, absolutely. So our transfer center, we're working with hospitals all around the region. And again, it's bi-directional. So even though it's a CHI Health transfer center. It's actually functioning on behalf of the state. And so our nurse team is, if we get a call from a hospital on the Kansas border that needs to move a patient for a higher level of care, they're working with, all the hospitals in the region to find an appropriate bed for that patient, not just CHI Health. So the transfer center is truly functioning as a resource of the state and is working with all providers across the region.
What happens if we reach critical mass and all beds are taken?
Well, I think it's unlikely that we would reach, critical mass where, quote, all beds were full, because we do have the ability to continue to scale back procedures if we really needed to. I think I've shared with you before, when we did our planning back in, early March, we believe that we could go from about 1,100 beds to almost 1,000 more, up to 2,000, just in CHI Health alone. That's how much physical capacity we have. The challenge, as we've noted before, is staff, and that's why we've been vigorously recruiting agency staff. These are traveling nurses to be able to bring more workforce into the state of Nebraska and into the region to really be able to support increased demand should it occur. As I've also said, I'll just reiterate for this group, is that it is, for us, it would be more challenging to deal with a tornado that hit one of our cities, and where we were trying to, take care of 300 people all at once that needed, significant levels of hospital care. The one thing about this pandemic and this virus is we are able to see trends and be able to prepare in advance. So, for example, we've gone from 170 to 208 patients over the course of a week. That kind of change in demand is much more manageable for health systems around the country, and it gives us the ability to work with our state officials, to work with our counterparts in healthcare, to be able to plan to be able to meet the demand, whatever it might occur, or whatever it might be.
We're going to skip ahead because I think you answered a whole bunch of questions in the series of questions that we had received. We're going to skip ahead to traveling nurses. How many traveling nurses are you bringing in? When did they first arrive, or when will they first arrive? And are you moving staff from other facilities?
Again, so similar question has come up in prior Zoom calls, but I'll answer it. So we've had some of our travelers started arriving in the last half of October. We have more slated to arrive over the next few weeks, and we have even more orders outstanding for nurses to arrive in early December. So we'll continue to see new nursing staff, as well as some other clinical staff beginning to arrive and work in our facilities over the next 4 to 6 weeks. We do have the capability as a health system. Again, there's 14 hospitals in our region. We're all on the same electronic medical record platform. We can move physicians, nurses, other health, ancillary health staff, like respiratory therapists, whatever. We can move them between communities, between hospitals if we need to. We also have 150 clinics across the state that are staffed with, not only physicians and other clinicians, but also nursing staff, nursing assistants, et cetera. We can tap into an even larger group of staff should we need to. Now, while we may be planning different scenarios, at this point, we've not needed to really start pulling any of those additional levers, other than hiring more agency nurses or travelers to bring in to the community. So that's where we stand today. What I would also say that I think should be very reassuring for most folks in the community is, the health systems, while we are competitors in one sense, in a situation like this, we're not. We're working very closely with all of the other health systems, in the region, and around the state to make sure that we are prepared and capable of caring for the community and whatever the community might need. And so that's been one of the great things that's come as a result of this pandemic is there's a lot of collaboration and a lot of cooperation of all the health systems. And I think that serves the citizens of Nebraska well.
Are you worried about staff burnout?
You know, I've mentioned this before. That is probably the, you know, one of the things that keeps me up at night is that, you know, this, just like the general public is maybe tired of the impact this virus has had on our life. I know our caregivers are absolutely tired. You know, as I said last week, if we end up with a bunch of traveling nurses and then we don't need them, you know, that'll be a wonderful opportunity for us to allow our regular staff to take some time off to you know, recharge and rest. And so I'm hopeful that we find ourselves in that situation over the next few weeks. But yeah, I think just fatigue, and quite frankly, the fatigue impacts all of us, and that may be partly why we're seeing more infections in the community. You know, as we let our guard down because we're just sort of tired of dealing with this, quote unquote, then, you know, it's pretty easy for this virus to take hold again and begin to spread more rapidly. So I think we're all tired. I know our caregivers are tired, but I also know that the work that they do, the commitment they have to the community is unlike no other. And regardless of how tired they are, they're getting up out of bed every morning and coming in because they know the community needs them. And, you know, that is the ultimate demonstration of human kindness.
Okay, so this is the last of the pre-submitted questions. We may have time for one or two questions on the chat, so be thinking of those. Here's your last question, pre-submitted. How can voters be safe at the polls? Is there concern with crowded polling places and after the election parties? Could this cause an outbreak?
I wouldn't expect it to cause an outbreak. I guess that's the way I'd answer the last part of that question. You know, again, it's critical that folks, when they're at the polling place, you know, do their best to maintain social distance, to wear masks, particularly if they're indoors and they're unable to maintain social distance. Simple things like using the hand sanitizer to just clean your hands after you've touched the polling machines, or you've, you know, filled out your ballot. I mean, those are the simple things that we all should be doing all the time anyway, and that will mitigate the risk. Given the fact that other than maybe standing in line, folks aren't going to have prolonged exposures to other people, at least close contact, I think, you know, voting is an incredibly low risk. And I personally, as a physician, I wouldn't want folks to not vote just because of their fear that, you know, they of COVID. I think they can vote safely. They just need to understand the regular precautions. I know, and I'm sure that the state and county governments have done everything they possibly can do to make the polling locations safe. And I don't think that this is going to be a huge issue for us in terms of, you know, increased number of cases as a result of voting.
Okay, I haven't received any questions via chat. This is your last chance to send those in. Cliff, did you have anything else you wanted to add?
No, just we'll, you know, continue to keep you all informed as you know, the facts on the ground change. I think kind of the key message is that, you know, we need to keep doing the things that we all can do as individuals to help mitigate the spread of this virus. We have to understand that this is, you know, a challenge because of the fact that it seems to be spread so readily by people that maybe aren't sick or have very minimal symptoms. And so we just need to keep our guard up. And also for folks to understand that, you know, all of the health systems are working together to make sure that that we're able to adequately care for the communities that entrust their care to us. So thank you. We'll see you in a week.